This is Dr. James Allen from the Division of Thoracic Surgery at Massachusetts General Hospital. I'll be giving a brief presentation on corrosive injuries of the esophagus for the Thoracic Surgery Directors Association requisite curriculum in thoracic surgery. Corrosive injuries of the esophagus typically occur with a bimodal age distribution. The first group affected are commonly young children, particularly toddlers, who accidentally ingest a variety of household chemicals. This accounts for approximately 5,000 cases of caustic ingestion per year currently. The next age group that tends to be affected are older adolescents and adults who ingest such chemicals in suicide attempts. This accounts for another 5,000 to 10,000 cases per year. The mortality of a caustic ingestion can be as high as 20% depending on the particular case series looked at, and there's considerable morbidity for anyone who survives a caustic ingestion. Caustic ingestions are comprised of ingestions of 1 strong acids or 2 strong bases, and we will consider both of these categories in the slides that follow. From a historical perspective, caustic ingestion first became a significant public health problem at the turn of the last century when lye-containing products became available for household use. These products are commonly used today even as a drain cleaning agent and are used to a lesser extent in the saponification process used to convert animal fatty acids or vegetable fatty acids into soap. Chevalier Jackson, a pioneer in thoracic surgery, was a big proponent of the Federal Caustic Act of 1929. The Federal Caustic Act was the first federal regulation which required product identification labels on various household chemicals to indicate their potential injurious ability. The Poison Control Center was established in 1953, which greatly enhanced public awareness of the dangers of these household chemicals and began to establish a central mechanism for coordinating the effective identification and treatment of various caustic and poisonous ingestions. The situation took a significant downturn in 1967 when liquid lye products were introduced to the household market. These were typically introduced for the purposes of unclogging drains, and they had concentrations of sodium hydroxide up to 40%. Concentrations of bases this high are quite injurious to the esophagus and to the upper gastrointestinal tract in general, and after the introduction of this class of products, the number of caustic ingestion mortalities rose sharply. The Poison Prevention Packaging Act of 1970 began to return the statistics to a more favorable range. This act was the act that mandated child-proof containers on a variety of common household chemicals and medications, and also specified a mandatory reduction in the concentration of chemicals that could be packaged for household use. We'll first consider strong acids. Strong acids are chemicals which have a low pH. They account for less than 30% of ingestions, and they typically include hydrochloric acid, bleach solutions, and phenol-containing compounds such as various Lysol-type cleaners. Strong acids are often noxious to smell or to taste, and sometimes this factor limits the amount of the ingestion, particularly of those ingestions that are unintentional. The strong acids cause a particular type of necrosis known as coagulative necrosis, and coagulative necrosis has a paradoxical protective effect by creating a coagulum of superficial tissue and mucus over the lining of the upper gastrointestinal tract, which may in fact limit the depth of penetration of the injury from an acid ingestion. It should be noted that household bleach solutions rarely causes full-thickness injury of the esophagus or the upper gastrointestinal tract. However, acids, if allowed to dwell in the stomach, certainly are capable of inducing a gastric perforation, and they tend to do this more frequently than causing esophageal perforations due to the protective effect of the coagulum and the fact that the acid's transit time through the esophagus is relatively quick. Here's an endoscopic picture of an esophagus that's been exposed to hydrochloric acid. What can be seen here is a number of coagulated submucosal blood vessels. Again, this effect has a somewhat paradoxical protective effect on the deeper layers of the esophagus, and a full thickness injury is rather uncommon. Turning now to strong bases. Strong bases are chemicals which have high pHs. They account for greater than 70% of ingestions, and they typically include sodium and potassium hydroxide and alkaline batteries, the small button-type batteries that toddlers seem to like to eat. These compounds are usually without taste or other aversive qualities, and unfortunately this will allow the toddler in particular to eat a large quantity of these items, particularly the solid lye compounds, without really realizing that they are causing themselves any harm. In contrast to the strong acids, the strong bases cause a liquefactive necrosis, and as such, injuries can occur at any point in the upper gastrointestinal tract, and they're oftentimes full thickness. The strong bases can cause an esophageal perforation with extension into the mediastinum, resulting in both a chemical and a bacterial mediastinitis. Perforations in the peritoneal cavity can certainly cause chemical peritonitis and bacterial peritonitis as well, and at the very least, caustic ingestions of the basic variety will induce stricture formation within the esophagus. The presentation of caustic ingestions frequently involves dysphagia, odynophagia, or drooling in a small child. Sometimes edema or erythema of the lips, tongue, and palate can also be seen. However, one has to keep in mind that oftentimes there are very few, if any, proximal symptoms for a caustic ingestion, and a patient can be largely asymptomatic even after a significant caustic ingestion. In fact, 20% of patients that present with a perforation of the distal esophagus or the stomach from a caustic ingestion will be asymptomatic proximally. The initial management of the caustic ingestion is typical of the initial management of any other acute problem. Attention must be paid to ensuring that an airway is secure. This may require no intervention at all in an awake child or adult who does not have significant proximal injury, or it may require a surgical airway such as an emergency cricothyrotomy or a semi-elective tracheostomy in order to secure a proper airway if proximal injuries are severe. The physician also needs to address electrolyte imbalances that may be inherent with these type of ingestions, and to provide general supportive and resuscitative care. It is important early on to obtain a thorough history, including the name of the substance ingested, the concentration of that substance, the amount of that substance ingested, and whether or not emesis has occurred. Emesis is something that is generally not desirable in a caustic ingestion because it tends to expose the esophagus to a repeat injury and oftentimes aggravates the severity of the injury, apart from placing the patient at risk for aspiration. Other things generally agreed upon in the initial management is that it's acceptable to rinse the face and mouth to try and reduce any contamination in this area. Again, it's generally agreed that emesis or the use of emetics is to be avoided. The role of gastric lavage, however, has been somewhat controversial, and most people feel that gastric lavage is usually too late to affect the ultimate severity of the injury, although it certainly would have a role if the caustic ingestion occurred relatively recently, certainly within the matter of a half hour or so. One has to keep in mind that if gastric lavage is being performed, that it is mandatory to protect the airway. Other people have considered the use of neutralizing agents in the case of an acid or base ingestion. In general, this is fairly impractical. Ingestions that are injurious typically involve strong acids or strong bases, and they would need to be neutralized by inordinately large quantities of weak bases or acids, respectively, which is just impractical from the point of view of the amount of volume that would need to be administered. This also may produce undesired emesis, again aggravating the chance of a repeat injury and also making an aspiration event more likely. Finally, neutralization of acids with bases or bases with acids tends to produce heat as a side effect, and a thermal injury component could be inadvertently introduced as well. As to endoscopy or esophagography, most people agree that endoscopy should be performed somewhere between 24 to 48 hours following ingestion. Early endoscopy may not allow sufficient time for an injury to demarcate, and late endoscopy carries a higher risk of iatrogenic perforation at a time when an esophagus is significantly at risk. Flexible endoscopy is generally preferred over rigid endoscopy. The flexible endoscope allows a comprehensive evaluation of the upper gastrointestinal tract, including the stomach and duodenum, which again is oftentimes necessary since patients may have little in the way of proximal injury but have more significant distal injury to the upper gastrointestinal tract. The one occasion when rigid esophagoscopy may be helpful is in the removal of the alkaline-type button batteries that typically would lodge in the cervical esophagus. Rigid equipment is oftentimes much easier to use in order to remove this type of a foreign body. It should be noted that these alkaline type button batteries, when they are in the esophagus, actually because of the salinity of the esophageal secretions in the body tissues, actually are participating in an electrical circuit and are discharging their electricity. This is what makes it much more likely for these button type batteries to lose their alkaline contents through the battery casing, such as we've all seen when a battery gets too old. Esophagography is something, again, that probably has limited value in this situation. The barium swallow or a gastrographin swallow is usually normal immediately following ingestion, although the finding of global atony suggests that a full thickness injury may indeed be present, although it doesn't necessarily indicate that a perforation will occur. If esophagography is done, water-soluble contrast should be used in case there is a perforation present. This would prevent the extravasation of barium into the mediastinum or the peritoneum. After injury, it's imperative that patients are properly observed. The clinician wants to monitor for signs of perforation of the gastrointestinal tract. Perforations can occur as late as 2 weeks following a caustic ingestion, and again, up to 20% of perforations will have little or no evidence of proximal injury. Many people also feel that esophageal rest is important. This can be done by keeping a patient NPO, using total parenteral nutrition, or using some form of a liquid diet. It's generally felt that solids that are retained within the esophagus at the time of an esophageal injury often promote additional inflammation and may enhance stricture formation. So certainly I think most people with an esophageal injury should stay off of a solid diet until the mucosa has rehealed. Antibiotics, steroids, and stents have been considered in the management of a caustic ingestion, and by and large have not shown to be effective. At the very best, these are unproven modalities that have been studied only in the literature in small numbers in studies that are relatively underpowered to detect a significant difference. At the present, I don't use any of these modalities in the management of caustic ingestion, although there is some variation in clinical practice in the use of these drugs and stents. Most caustic ingestions will induce stricture formation to some degree. These strictures can be quite long, and they can consist of a long tortuous stricture or a series of multiple webs. The gross anatomy of one such stricture is shown here in this slide. These strictures are usually dilatable to some degree with standard transoral dilation techniques. I prefer the use of a wire-guided dilator such as a Savory dilator, using a fluoroscopic C-arm intraoperatively to ensure that my dilator is passing correctly. I think this is important, particularly given the fact that most of these strictures are relatively long and are not concentric. If a stricture proves to be not manageable with repeat dilation, which may include even home dilation by the patient, him or herself, one can consider elective resection and reconstruction of the upper gastrointestinal tract, which typically would include an esophagectomy with a gastric pull-up, assuming the gastric conduit is suitable. Management of perforation of the upper gastrointestinal tract is handled as it would be in any other surgical situation where there is a loss of continuity of the upper GI tract. The principal surgical objectives are to prevent and stop soilage of the mediastinum, to prevent and stop soilage of the peritoneum, to prevent the sepsis which would occur subsequently, to debride necrotic tissue, however, to try and to preserve as much healthy esophagus and stomach as possible, as these may be used in subsequent reconstructions, and to establish enteral access, which may be in the form of a gastrostomy or a jejunostomy tube. Restoration of the continuity of the upper gastrointestinal tract is not an immediate surgical priority. In fact, one would question whether one should even attempt to perform some sort of a reconstructive procedure in the face of an injury of this magnitude. Instead, I would prefer to divert, drain, and debride during my initial surgery, which may entail doing an esophagogastrectomy and creating a cervical esophagostomy, or more commonly known as a spit fistula, and then bring the patient back after they have fully recovered from their injury and inflammation in the mediastinum has subsided for a reconstruction, which may involve a gastric pull-up or a colonic or a jejunal interposition, and I would consider doing these reconstructions through the retrosternal space rather than attempting to re-access the chest or posterior mediastinum, which is likely to have a considerable amount of scar in it at this point. This is Dr. Allen completing a presentation on corrosive injuries of the esophagus. I thank you for your attention.